Hello friends, welcome to our today's lecture on irritable bowel syndrome. If you haven't seen my first video on inflammatory bowel disease, please do watch it. The link for inflammatory bowel disease will be there in the description box. Please do have a look. Starting on with the irritable bowel syndrome or IBS, it is a pattern of recurrent bouts is actually a short period of intense activity of abdominal pain and abnormal bowel motility, which cause things like constipation or diarrhea, or a mixture of two, and oftentimes the abdominal pain improves after a bowel movement. Although it sounds similar, IBS or irritable bowel syndrome is different from inflammatory bowel disease or IBD, which involves some of the same symptoms of IBS but also includes inflammation. IBD also include inflammation, ulcers and other damage to the bowel, whereas IBS does not involve this and instead can be thought of as a functional disorder which only cause some abnormal bowel motility leading to constipation, diarrhea or the mixture of the two. So please do remember this, that both IBS and IBD are different. Don't get confused. Now moving on with the clinical presentation of irritable bowel syndrome. This could be recurrent abdominal pain associated with two or more than two of the following. That is, it could be related to defecation, that could be increased defecation or decreased defecation, it depends. Then there can be change in the stool frequency, and also there can be change in the form or consistency of the stool. Normally there is no structural abnormalities and they are most commonly found in middle-aged females. The chronic symptoms may be diarrhea predominant or constipation predominant, or whether it can be the mixture of both the diarrhea predominance and the constipation predominance. Pathophysiology is multifaceted and the first line treatment is lifestyle modification and dietary changes. Now moving on with pathogenesis. With regard to abdominal pain, a lot of people with irritable bowel syndrome has visceral hypersensitivity, which means that the sensory nerve endings in the intestinal wall have an abnormally strong response to stimuli like stretching during and after a meal. This visceral hypersensitivity might explain why people with the disease experience recurrent abdominal pain. Now moving on with regard to abnormal bowel motility, the underlying mechanism is little less clear. One clue is that eating foods that contain short chain carbohydrates such as lactose and fructose often trigger the symptoms. One possible explanation is that unabsorbed short chain carbohydrates, they act as solutes that draw water across the gastrointestinal wall and into the lumen. So in addition to triggering visceral hypersensitivity which causes pain, that excess water can also cause smooth muscle lining the intestines to spasm and create diarrhea if the excess water is not reabsorbed back into the body. To make matters worse, the unabsorbed short chain carbohydrates are often metabolized by gastrointestinal bacterial flora, which produce gas that could trigger more bloating, spasm, or pain. Now, the treatment and management of irritable bowel syndrome includes the things like diet modification, like avoiding certain foods like apples, beans, and cauliflower, all of which have short chain carbohydrates. In addition, to treat constipation, soluble fibers, stool softeners, and osmotic laxatives can help. Whereas for gastrointestinal spasm and pain, antidiarrheals like serotonin antagonists and antimuscarinic medications can help. Finally, managing things like stress and controlling feelings of anxiety and depression can also help with symptoms of irritable bowel syndrome. Now let us start with the clinical scenario. In this, a 35-year-old woman presents with fever, diarrhea and right lower quadrant abdominal pain. She has had similar symptoms intermittently for 10 years. Pulse is 105 per minute and respirations are 22 per minute. Physical examination reveals 4/5 strength bilaterally in the upper and lower extremities and diminished vibratory sensation in the feet. Laboratory tests shows a WBC count of 12,000 per mm cube, a hemoglobin concentration of 9 gram per deciliter, and a mean corpuscular volume of 112 FL. Which of the following is most likely to be found on further workup? Pause the video and think of the answer. The patient's presentation consists of intermittent diarrhea, fever, and abdominal pain. This is suggestive of Crohn's disease. Now, the Crohn's disease often involves inflammation of the terminal ileum. The terminal ileum is the site of vitamin B12 absorption, and chronic terminal ileitis may lead to megaloblastic anemia. That results from vitamin B12 deficiency, and thus we can see here the elevated mean corpuscular volume. And the vitamin B12 deficiency is associated with a number of clinical and laboratory abnormalities, including fatigue and peripheral neuropathy, as indicated here by diminished vibratory sensation in the feet, as well as tingling and numbness in the hands or feet, along with diminished vibratory sense. Then elevated levels of methyl malonic acid and homocysteine may be seen with vitamin B12 deficiency, because vitamin B12 is a coenzyme for methylmalonyl coenzyme A mutase, the enzyme that converts methylmalonyl CoA to succinyl CoA. A deficiency in vitamin B12 will subsequently result in an elevated methylmalonic acid level. That is due to this deficiency of the enzyme methylmalonyl CoA mutase, as the vitamin B12 is the coenzyme. Now, vitamin B12 is also a coenzyme for the enzyme methyltransferase, which is responsible for the formation of methionine from homocysteine. So, the answer to this question is B, that is the elevated methylmalonic acid level. The next question says that a 20-year-old man comes to the clinic due to bloody diarrhea and fatigue for the past 9 months. He has no history of major medical illness, although he does report pain in the knees and hands that seems to worsen with his diarrhea. A colonoscopy is performed which shows diffuse rectal hemorrhagic ulcers and multiple areas of rectal granulation tissue. Which of the following disorders is associated with this patient's current condition? Pause the video and think of the answer. This patient most likely has ulcerative colitis, given his presentation with episodes of bloody diarrhea and abnormal colonoscopic findings that includes rectal hemorrhagic ulcers and granulation tissues, which is also known as pseudopolyps. His joint pain is likely caused by an inflammatory arthritis which is associated with ulcerative colitis. Primary sclerosing cholangitis is strongly associated with ulcerative colitis and may manifest as jaundice and increased alkaline phosphatase activity. Although only a minority of individuals with ulcerative colitis have primary sclerosing cholangitis, like 2.5% to 7.5%, but around 80% of patients with primary sclerosing cholangitis have ulcerative colitis or Crohn's disease. Thus, the disorder which is associated with the patient's patient's current condition is primary sclerosing cholangitis, and it is characterized by inflammation and progressive obliterative fibrosis of intra and extrahepatic bile ducts. The next scenario presents that a 43-year-old man comes to the physician because of bloody diarrhea, abdominal cramping, fatigue, and severe pruritus for the past month. Medical history is significant for ulcerative colitis. Temperature is 37.1 degrees Celsius. Pulse is 103 per minute. Respirations are 20 per minute, and blood pressure is 105 per 80 mm Hg. Physical examination reveals scleral icterus and diffuse exfoliations. Which of the following additional laboratory findings would most likely to be expected in this patient? Pause the video and think of the answer. Now, the patient's symptoms of bloody diarrhea, abdominal cramping, they are consistent with the diagnosis of ulcerative colitis, while the presence of fatigue and pruritus as well as scleral icterus are suggestive of primary sclerosing cholangitis. Now, the primary sclerosing cholangitis is a chronic cholestatic disease that is often linked with inflammatory bowel disease, and it is characterized by inflammation and obliterative fibrosis and segmental constriction of the intrahepatic and extrahepatic bile ducts. Normally, it is seen that the patients with primary sclerosing cholangitis has elevated alkaline phosphatase. So, the additional laboratory finding that would be expected in this patient will be elevated alkaline phosphatase. Why there will be no decreased ceruloplasmin? Because this is the condition or is a characteristic of Wilson's disease. Whereas this positive CA and CA is mostly seen in granulomatosis with polyangiitis condition, and this elevated carbohydrate antigen 19.9 or 19-9 levels are present in patients with pancreatic adenocarcinoma. So the most common likely answer to this question will be B, elevated alkaline phosphatase, which is associated with primary sclerosing cholangitis. In this question, a 32-year-old woman presents to the clinic because of recurrent abdominal pain relieved by alternating episodes of diarrhea and constipation. These episodes have been occurring almost daily for the past 15 months. Her symptoms are worsened by stress but are not affected by her diet. The patient denies fever or weight loss. Abdominal and digital rectal examinations are normal. Complete blood count, serum albumin, and C-reactive protein are normal. The most likely diagnosis in this patient is commonly associated with which of the following findings? Pause the video and think of the answer. This patient's history of vague abdominal complaints without red flags like anemia, weight loss is most consistent with diagnosis of irritable bowel syndrome. Irritable bowel syndrome is a chronic functional gastrointestinal disorder characterized by altered bowel habits like constipation, diarrhea, or alternating constipation and diarrhea with abdominal pain. The risk factors include anxiety, depression, personality disorders, and history of abuse. Because irritable bowel syndrome does not lead to demonstrable mucosal changes, a biopsy specimen of the small bowel or colon will demonstrate normal histology. So the most likely diagnosis which is normally or commonly associated with this finding is normal small bowel histology. Now, this villus flattening in the small intestine is actually the characteristic of celiac disease, which we will study in our upcoming videos. So, the answer to this question is B, normal small bowel histology. Now, in this question, a 25-year-old man comes to the office because of abdominal pain and loose bloody stools. He has lost 6.8 kg in the past 3 months. Temperature is 37.3 degrees Celsius. Abdominal examination is notable for hypoactive bowel sounds and diffuse tenderness. A colonoscopy reveals diffuse continuous ulcerations of the intestinal mucosa extending proximally from the rectum to the splenic flexure. A diagnosis is made and genetic testing reveals that the patient carries a human leukocyte antigen subtype commonly associated with disease his disease. Which of the following is a disease associated with this patient's most likely human leukocyte antigen subtype? Pause the video and think of the answer. On the basis of the patient's presentation, his symptoms of abdominal pain and loose bloody stools with the results of his colonoscopy revealing the diffuse continuous ulceration that extends from the rectum to the splenic flexure, all this suggests of the diagnosis with ulcerative colitis, that is an inflammatory bowel disease of unknown etiology that affects the rectum and may extend proximally to the colon. So the ulcerative colitis is actually associated with human leukocyte antigen B27 subtype. It is a major histocompatibility complex class 1 molecule that encompasses 25 glycoproteins and is encoded on chromosome 6p. The diseases associated with the HLA-B27 subtypes can be remembered with the mnemonic PAIR, P-A-I-R, PAIR, where the P stands for psoriasis, A stands for ankylosing spondylitis, I stands for inflammatory bowel disease, and the R stands for reactive arthritis. So this is the mnemonic to remember the disease associated with human leukocyte antigen B27. Thus, the answer to this question will be A. Ankylosing spondylitis, which is an inflammatory disease of the spine, sacroiliac joints, and in some cases, it also includes the extra articular structures such as the eyes. In this question, a 28-year-old man with Crohn's disease comes to the emergency department because of a 24-hour history of flank pain with radiation to his groin. For the past several months, he has had diarrhea with foul-smelling stools that float in the toilet. His diet and appetite are normal, and he drinks extra fluids each day to avoid dehydration. Vital signs are normal. Physical examination shows left costovertebral angle tenderness. Laboratory testing shows normal serum calcium and phosphate levels. Urine analysis shows specific gravity of 1.010, pH of 6.5, 3 plus blood, and numerous crystals. Which of the following most likely resulted in the development of this patient's kidney stones? Pause the video and think of the answer. In this scenario, the patient with Crohn's disease has flank pain, hematuria, and crystalluria. This all suggests nephrolithiasis. Now, kidney stones in patients with steatorrhea are most often due to calcium oxalate. Now, how does it occur? In the intestine, calcium normally binds with oxalate, creating complexes that are mostly eliminated in the stool. In the setting of steatorrhea, excess intestinal lipids complex with calcium to result in increased free oxalate, which is absorbed, thus increasing serum oxalate, which is normally eliminated in the urine. As oxalate concentration increases in urine, calcium oxalate crystals form, which causes stone formation. This process occurs in Crohn's disease as the ileum is responsible for bile acid reabsorption, and the Crohn's disease of the ileum can result in loss of bile acids resulting in steatorrhea. Thus, in this case, the excess intestinal lipids actually lead to the formation or the development of the patient's kidney stones. Now, in this question, a 24-year-old man is hospitalized because of a 2-week history of severe abdominal pain and bloody diarrhea. A colonoscopy shows contiguous inflammation beginning at the rectum and extending to the splenic flexure. His physician prescribes an anti-metabolite prodrug that works by inhibiting purine synthesis. Which of the following is an adverse effect of the most likely prescribed medication? Pause the video and think of the answer. Now, this patient likely has ulcerative colitis based on his symptoms of bloody diarrhea, abdominal pain, and contiguous inflammatory findings on colonoscopy. He was most likely prescribed azathioprine, an immunosuppressive medication sometimes used for long-term control of inflammatory bowel disease. Azathioprine is an anti-metabolite prodrug which is converted to 6-mercaptopurine and inhibits purine synthesis and metabolism. Now, because azathioprine affects proliferating cells such as WBCs, patients will have a reduction in the number of white blood cell counts or WBCs count, leading to leukopenia, and thus the patients receiving azathioprine has an increased susceptibility to infection. Thus, the adverse effect of the prescribed medication, that is azathioprine, is increased susceptibility to infection. In this question, a 35-year-old male presents to the office because of intermittent loose stools and abdominal pain for the past 6 months. He also has occasional joint pain that began around the same time. Colonoscopy reveals significant inflammation and ulceration of the terminal ileum. Which of the following would be targeted by the treatment for this patient's most likely disease? Pause the video and think of the answer. Now, this patient's presentation is classic for Crohn's disease. The most commonly affected site is the terminal ileum. Although Crohn's disease can be present anywhere in the gastrointestinal tract from mouth to anus, but the most commonly affected is the terminal ileum. Crohn's disease commonly presents with loose stools, intermittent abdominal pain, and occasional joint pain. Now, for severe Crohn's disease or disease that is refractory to this to first-line treatments of the Crohn's disease, an anti-tumor necrosis factor alpha monoclonal antibody such as infliximab or adalimumab may be used for the treatment. So, the treatment targeted for the patient's most likely disease will be against tumor necrosis factor alpha. Next two questions, the question 9 and question 10 are for you. Please do comment your answers in the comment section below. In this question, a 23-year-old woman presents to the clinic with fatigue, diarrhea, weight loss, and low-grade fevers for 5 months. Her bowel movements are loose, frequently bloody, and occur 6 to 8 times a day. Colonoscopy reveals lesions in the rectum that extend proximally and contiguously to the sigmoid colon. Which of the following histologic finding is most characteristic of this condition? Think of the answer and please comment your answer in the comment section. The next question says that a 20-year-old female comes to the clinic because of crampy abdominal pain for the past 3 months and non-bloody diarrhea beginning 5 days ago. She also reports an unintentional 3.6 kg weight loss, temperature is 37.9 degrees Celsius. Physical examination reveals aphthous ulcers in her mouth and tenderness to the right lower quadrant. She has erythematous bumps on the anterior aspect of her lower extremities that are tender to palpation. Her erythrocyte sedimentation rate is 51 mm per hour. A CT scan shows disease in intermittent patches in her ileum, descending colon, and transverse colon. Which of the following pathologic features would be most likely in this patient's gut? Pause the video and think of the answer, and do please comment your answer in the comment section below. Thanks for watching. If you like my videos, I request you all to please subscribe and share as much as you can. Also do click the bell icon for more updates.